pregnancy diagnostic tests, especially ultrasound and amniosis feces, and then postpartum hemorrhage. That's basically, the yeah, discomforts of pregnancy, the different discomforts on the different trimesters. Like urinary frequency, back ache, leg cramps, hyperemesis gravidarum, right? Those things. Okay. And then, as I mentioned, diagnostic tests like amnios and feces, ultrasound. Oh, and GT-PAL. Who remembers GT-PAL? GT-PAL scoring.
Yeah.
Right? GT-PAL scoring. So we'll discuss that. And signs of pregnancy. And there's only one or two questions on it, but we'll help out with it. You have, there are three signs of pregnancy, right? You have presumptive, probable, and positive, right? And then, of course, postpartum hemorrhaging, and then a little bit on placenta previa and abruptio placenta, and HELP. Everyone still remembers HELP, right? HELP syndrome. HEL,
LP.
LP, yeah, HEL, okay. So that's going to be our focus. Hopefully we can finish that on Saturday so that by Sunday we can go to peds and then mental health and then, yeah, that's it. Monday will be just, chill. Chill. Monday we're just gonna chill. Paper bags. Do you want it to be brown or it could be any color? Brown.
Yun yung talaga, yun lalabas mo dito sa...
Has to be brown,
Ha?
right?
Yung mga sinasabi. Patong doon.
Alright.
Lalabas na sa...
Let's see. Okay, so.
I don't know.
5:31. Alright, let's start.
Usually, sinasabi niya na, oh, okay, this will be on the exit bago niya so, I usually take notes, color-coded at least, kung sinasabi niya.
Alright, so our focus today is Surg. But before we do that, I had to add a few things. There was a few things that I saw that might be coming up, so I added it here, okay? We're going to discuss a few more meds that I think will be coming out. So I want to make sure that I go over it so that we don't have any problem with it, okay, when it comes out. So I did put a few practice questions and we'll discuss a few things about it. Okay? So here's the first one. So, diuretic. Alright, so diuretics. There's one diuretic that they're really gonna ask you on, especially the therapeutic effect of this diuretic, and that is furosemide or Lasix. Perfect timing because one of the research that we will be going over is heart failure, especially the two types, which is right-sided and left-sided heart failure. So I want to go over this because the question is on the application of this medication on heart failure, but it's asking about therapeutic effect. Okay, so very important to know, guys, so that when this type of question comes up on your farm, when it says or when it asks about therapeutic effect, it's not asking you how the medication works. That's not what it's asking you. What it's asking you is what is the benefit that the patient gets from it. The benefit that the patient gets from it, okay? So if you look at this, try to apply that, what I said, and then let's go ahead and answer. What do you think would be the answer?
I'll say A.
B. Who says A? Who says B?
So I don't think it has anything to do with the lungs.
Who says D? Everyone's still thinking about it, right? Okay, go ahead. I think about it. Alright, so the answer is, this is the answer, okay? Again, on the application of heart failure, especially because heart failure, you have two types, right-sided and left-sided, right?
Mm-hmm.
In this situation, it's left-sided, so which means if it's a left-sided heart failure,
Pulmonary.
it also involves another organ, which is
Lungs.
the lungs.
So it's B.
So again, therapeutic effect would be letter B.
Yeah.
That's the right answer. Therapy decrease pulmonary congestion. Okay, so we all know diuretic works by what? Preventing water from being reabsorbed by the tubes, right, and the kidney, so that it can be excreted out, resulting into an increase in urine output. But that's just how it works. It's not really what the benefit that the patient gets from it. So what is the benefit that the patient gets from it? You increase the urine output, you actually remove signs and symptoms of fluid
Overload.
Okay, so you are removing signs and symptoms of fluid overload. And one of the signs and symptoms of fluid overload on left-sided heart failure is pink frothy sputum, crackles in the lung, and pulmonary
Congestion.
Okay, so don't forget that. Again, therapeutic effect is not how it works, but rather the benefit that the patient gets from it. Okay, don't forget that, class. All right. Next one. There's another one that I added because I think this is really going to be there. Statins. So when we say statins, we have different statins: atorvastatin, simvastatin, and what's the other one? Lovastatin. Correct. That's right. Lovastatin. Statin drugs. What's the purpose?
B.
It is to decrease blood cholesterol level. Correct. That's the purpose. It is for the process of decreasing blood cholesterol level. Now the question is, while teaching a patient about statin therapy, the nurse should emphasize the importance of monitoring which of the following symptoms.
B.
The next one is the same. Oh no, it's a different question. So what's the right answer here?
B.
Letter B. Very good. So statin drugs are very notorious for causing muscle pain, muscle damage, especially damage to the joints. Okay? So if a patient starts complaining of muscle pain or joint pain, that's something that has to be what? Reported immediately to the physician. Now, other than that, statin drugs are also hepatotoxic.
Toxic.
What does that mean? It damages the
Liver.
So early manifestations of possible liver damage also should be reported to the physician, just like what? Jaundice. Right? You start seeing your patient start to become jaundiced, you're taking statin drugs, you want to make sure you hold the dose, report it immediately to the physician, because that could be a sign of liver damage. Okay, so again, it's hepatotoxic, so you want to make sure you're watching out for the patient's liver also. Okay, so again, muscles, joints, and liver, those are the ones that are affected the most. Okay, alright. Very good. Next one. Here's another one. This is on phenytoin. What is the other name for phenytoin? Dilantin. Very good. Dilantin is under what classification of medication? CNS depressant, primarily anti-epileptic, convulsive. Very good. Anticonvulsive or anti-epileptics, right? It is a CNS depressant.
C.
The nurse is teaching a patient about phenytoin or dilantin. So again, I'm going to write that down for those who are thinking what was the other name. So the other name is, here it is, dilantin. Okay, so don't forget that. That's the other name of phenytoin, dilantin. Okay? Now, question is, which statement by the patient indicates a need for further teaching? So something that the patient said that is wrong. Right. The answer is letter B. Correct. This is the type of medication that, because it's an anti-epileptic, anticonvulsant, you have to take it for life.
Okay.
Okay. There is also a certain blood level that has to be maintained, which is 10 to 20. Very good. 20. Okay. So you need to make sure that you're monitoring that as well, and the patient needs to be aware that they need to avoid alcohol. And doing alcohol with phenidone or Tylenol.
What's this right there?
Okay.
Oh, the.
Right now, other than that, okay, dilantin can also cause an increased risk for bleeding, okay, especially bleeding of the gums.
Okay.
So that's why patients on dilantin are advised to use soft bristle brush and not to floss. Okay, so avoid flossing and use soft bristle brush. Okay, because it can cause gingival hyperplasia. Okay. Gingival hyperplasia. Okay. So that's the one that requires further teaching because they cannot stop. They have to take it for
life.
And again, maintain a dilantin blood level of what? 10 to 20. Alright, here's another one. Isosorbide dinitrate. In this situation though, I think we didn't really go over as much the adverse effect. And again though, isosorbide dinitrate, what's the other name for this?
Nitroglycerin.
Nitroglycerin. Okay. For the management of angina or MI, which of the following adverse effects should the nurse monitor for?
Headache.
The answer is
C.
letter C. Now always remember this though. This is an expected, alright? Take note. This is an expected adverse effect of the medication, meaning that even though the patient experiences headache, are they supposed to stop taking it?
No.
You just have to explain that over time, the headache will start to what?
Go away.
Decrease
Yeah.
or get better. But they will experience it, especially the first time they take isosorbide dinitrate. But again, they're not supposed to what? To stop. Okay, now other than headache, they're also going to experience palpitations and flushing. That's also okay. That's expected. That's expected. Right? What's not expected is when they start having what? Orthostatic hypotension. That one, you really have to hold the medication and report it to the physician. Okay? But palpitations and flushing, headache, that is expected. You just have to tell the patient it will get better with time. But keep taking the what? The medication. Okay? So again, the patient can take it 3 times, 5 minutes, months. Okay? Right now, in the situation that the nitro is used as a patch, don't forget, it has to be placed on the part of the body that has less hair. Or if it does have a lot of hair, trim it, don't shave. Okay, you don't shave the hair, you actually what? Trim. Shaving can cause damage to the skin, which can cause injury to the nitro. Right? And don't forget, nitro patches are supposed to be 10 to 12 hours on, 10 to 12 hours off. Okay, very important. Okay. Right? So, why? Because we don't want the patient to develop tolerance. Correct, to the medication. Okay, so putting the medication for a long time can lead to the development of tolerance, meaning they're going to be resistant to it, and they're going to need higher and higher dose. Okay. Also, please remember that if you are going to put a new patch, please make sure that the original site where you put the medication, you clean it and remove all medication before you put a new patch. Yes, rotate sites, correct. Rotating sites is also important. Just like, when you're administering insulin or any type of injection, you rotate sites. Yes, you rotate sites. The only site though that you don't want to put nitro patches is below the waist.
Okay.
You don't want here. Alright? not on the leg area, not on the thigh area, and not on the buttocks. Okay? No one might find it.
Don't put patches below waist.
It takes a while. Because it's transdermal, it might take about 30 minutes. And that's why, remember, transdermal patches are not for acute application. Transdermal are more for maintenance, prophylaxis. And if they start having chest pain, even though they have a patch, what do? You give them something. They don't kick in that fast. It takes time, right? So for any type of acute chest pain or angina, what type of nitro do we give?
Sublingual.
Okay, sublingual. But again, don't remove the patch. And don't forget, when you remove the patch, you have to fold it, right? The inside fold together so we don't get any accident of exposure. Use gloves. Alright, very good. Awesome. Let's see, next one. While teaching a patient about isosorbide, which adverse effects should the nurse emphasize that the patient should report? Dizziness upon
Standing.
That's it. Orthostatic hypotension. Right? So, headache, flushing, palpitation, that's all expected. Right? But once they start having dizziness upon standing, that's not good. That means that they're developing orthostatic hypotension, meaning that their blood pressure is actually dropping. Okay. Alright, next one. We have 2 more medication after this. What is the best advice a nurse can give to a patient to minimize gastrointestinal side effects associated with doxycycline? So doxycycline is going to be on our exit. It's part of the list that I gave you guys, right? What type of medication is doxycycline? It's an antibiotic. Okay?
What's that about?
It's an antibiotic for the treatment of mainly bacterial infection. Okay? So, one thing that I want you guys to remember though, other than GI upset, doxycycline is also notorious for causing the same adverse effects like statin, which is muscle pain or joint pain. Okay? So if anyone starts reporting about muscle ache or joint aches about this, that's also something that you have to report immediately to the physician. Okay? So that's one similarity that that statins, this one, and cephalosporin. Those 3 medications, they share very similar adverse effect, which is the muscle damage. Okay. So statin drugs, doxycycline, and cephalosporin. I'm not mistaken.
Cephalosporin?
I think cephalosporin.
Oh,
Is there an H? Where? At the R? PH? Right there?
I don't know.
I got it, right? Oh yeah, I already got it.
Yeah, you got it right the first time. So don't forget cephalosporin, doxycycline, statin drugs, they share one very similar adverse effect, which is the muscle damage or joint pains. What do? Report that immediately to the physician. So how do we relieve? What do you think is something that we can do to relieve the associated GI upsets? Take with food. B.
Take the medication
With food.
with
Food.
food. It's actually with water.
Water?
With water.
Really?
Take it with a full glass of water. Okay. Although food sometimes help, the problem though is it said for milk. Milk actually prevents the absorption of toxicity.
Okay.
Okay. Take it with food, yes, but not with milk. Take it with water, yes. That's a good answer. Just take it with water. Alright, very good. Next one.
A patient on doxycycline therapy is advised to avoid sun exposure. What is the best rationale for this instruction? This is another adverse effect. It causes
Photosensitivity.
Cool. So, it causes photosensitivity. So there you go. Another thing to remember. Okay. So when it comes to adverse effects, GI absent like nausea and vomiting, right? And then muscle damage or joint aches, and then photosensitivity. It's another one that doxycycline can actually do. Can cause photosensitivity. Very good. All right, last one. Here's our last medication that I forgot yesterday. What should the nurse instruct the patient regarding the timing of Montelukis or Advair? Now, before we answer this, what's Advair for? Asthma, right? It's a bronchodilator. Right? It's a pill. It's a bronchodilator, primarily given for patient with history of asthma. It is better taken at what time of the day? In the evening, right? Before the child or the patient sleeps. Because in the evening, you actually get more episodes of asthma. Okay? Especially with the changes in temperature. So, other than that, other than knowing that it's best given in the evening, okay, what else is important for the nurse to say? Well, yes, that's what it is. So, but other than that, take it at the same time each day. Preferably what time?
Night.
Okay. Good job. Okay, so don't forget those. Okay, guys. Additional stuff. Additional. Now, really quick, Monique. I know she's on her way. She got stuff.
I'm here.
She's here already? Oh. Good. Pass by my radar. Alright. Fabiolo. It's Gallardo. Don't forget to sign, okay? And then Marissa. Don't forget to sign, okay? Yes. Yes, actually that's part of our diabetes. So it's part of the question on the exit. It's mixed. So we'll go over that in MedSurg. So here we go. Yes, MedSurg. We did already just go on the cycling. And so it's more of identifying the and what to do. There's not that much evidence.
Oh, the Bernabe. Good at mental health.
No, NGN is not medication. Psychosis. Psychosis. I don't have enough psychosis. You know the best thing to do is I open to take the mental health practice ASD to assist psychosis. Okay, thank you. Yeah, but that's the best thing to do. And don't forget, the focus is so big.
$10,000 bonus funds. Shit. What the hell is this? Okay, whatever.
Alright guys, here we go.
Alright.
Next Saturday, our focus will be NG and case studies. So we're going to be doing NG and case studies before we start with our daily exit.
What do I have this?
Saturday. Alright, so here we go. First topic on our Surg. A nurse is reinforcing teaching with a client has type 2 diabetes mellitus, and the nurse determines the teaching has been effective when the client identifies which of the following manifestation of hypoglycemia. So don't forget, on our exit, those are the two things that they will ask you on cues. Cues to hypo and cues to hyper. Alright, now, those things are of course related to the topic on the exit of diabetes mellitus. Alright, so on this question though, it's asking about hypo. Okay, so trick, have to remember, hypo, think of full and
Clammy. Need some candy.
Full and clammy, need some candy. Alright, so what are the signs of hypoglycemia?
Sweating.
A, is A hypo?
Yes.
Yes, this is clammy, right? Diaphoresis or sweating, that's hypoglycemia. So A is the right answer. How about B? Polyuria. That is
Hyper.
what? Hyper. I'm on it, guys. Sorry about that. We'll get some tape later on. So don't forget, if the manifestation is polyuria, polydipsia, polyphagia, right? They're all what?
Hyper.
Hyperglycemia. Okay, so excessive urinating, excessive thirst, excessive hunger, right? Or excessive eating, right? Polyphagia, right? Eating. That is signs of hyper. Also, there are some signs of hyper that are not usually mentioned, but they are signs like, let's say, for example, Kussmaul's
Respiration. Yep.
Kussmaul's is not like, your traditional, but it is hyperglycemia as a sign of what? DKA, right? The other one is fruity bread or acetone bread. Also not your regular hyperglycemia, but it is still hyperglycemia, right? Because it's a sign of DKA, meaning ketoacidosis, right? So, polyuria, polydipsia, we all know that one. We can remove that.
Yeah.
Right? Because that automatic is hyperglycemia. Okay? That automatic will be hyper. Okay, so you already know you can eliminate that and that because that is hyper. This one, hypo. How about blurry vision? Yes. Double vision, blurry vision, that's hypo. Headache is another one. How about tachycardia? Yes, that is also hypo. And acetone bread? No,
Hyper.
that is hyper. So, an easy way to remember this, I've always mentioned this to my class. Tires. And then just add headache and double vision. Right? So, tires HTV. Alright, so what does TARC stand for? Tachycardia, tachy, right? Irritability. This one is restless, excessively hungry, not eating a lot, okay, but hungry.
Diaphoresis.
Diaphoresis, and this one is shaky. Shaky. And then headache and double vision or blurred vision. Okay. That's an acronym that might help you in remembering what? Hypoglycemia. And then hyper, hot and dry.
Sugar's high.
You get they're hot and dry, they're sugar high. All the polys, whose moms? Acetone bread, right? Okay, so don't forget that one are all the signs of hypoglycemia. Yeah, this one though, the best answer for someone who is hyper is more of excessive eating. Excessive hunger falls more into hypo. Remember when you're hypo and you're not eating, what do you do? But excessive eating is more of hyper. Alright, so don't forget that. Excessive eating is more for hyper, excessive hunger is more for hypo. Alright, very good. Next one. Oh!
What happened?
Yeah, you got it, you got it. Alright, next one. Insulin. A nurse is collecting data from a client who has diabetes mellitus. The client is confused, flushed, and has acetone odor in his breath. The nurse should anticipate the prescription of which of the following types of insulin to treat the client.
Regular, B? Regular insulin?
So this would be what type of insulin?
B?
Regular. Very good. Okay, so don't forget, your patient by description, if you think about it, is actually experiencing
DKA.
Right? Now, the number one thing that's very important for DKA patient is hydration, right? Followed by
Insulin.
insulin. Okay, now, why is it though that hydration is the number one thing for the management of DKA followed by insulin? What happens? Right. When the patient has DKA, the patient develops severe
Dehydration.
polyuria. Why? Because it's a body's defense mechanism to try and flush out all of the excess sugar and acetone. So what happens? The patient cannot stop urinating until they become what? Dehydrated, and they can die of hypovolemic shock. Right? They can die of hypovolemic shock. Now, there's a question on your exit related to hypovolemic shock. How do you position a patient experiencing hypovolemic shock?
Trendelenburg?
The answer is Trendelenburg.
Oh,
now,
that's
here's the
Trendelenburg.
thing. Alright. Art 101.
Position in Trendelenburg.
There's two though, that's gonna be on your exit. If they were gonna show you a picture or a description, which one you pick is the best answer. They're both Trendelenburg. Which one do you pick? So the answer is this one.
Really?
This one is the best answer. This is what we call as modified Trendelenburg. Okay? Now, if there's no modified Trendelenburg on the option, what's the next best answer?
Regular
This one, which
Trendelenburg.
is
Trendelenburg.
This one is Trendelenburg. Right? One is modified, the other one is true Trendelenburg. So the best answer again, don't forget, is modified Trendelenburg. If that's not part of the option, what answer are you gonna pick?
Trendelenburg.
Trendelenburg. Right? Now what's the purpose of Trendelenburg? You want the blood to go to the most vital organ of the body, which is the brain in cases of hypovolemic shock. Okay? So it's very important, you will see that if a patient develops DKA, the first thing you're gonna give the patient is what? Bolus IV fluids. You're gonna load them up with IV fluids to make sure that the patient can maintain what? Circulation, and they don't develop, severe hypovolemia. Now, on top of that IV fluids for hydration, right? They will actually add insulin. What kind of insulin?
Regular.
Regular. Because regular is the only type of insulin that can be given IV and then at the same time can be given sub-Q. Okay? So, that's how it's given. They will give the patient insulin together with the IV fluids. They will monitor the blood sugar of the patient. Alright? Now, you'll be surprised though, the hydration that they give comes with dextrose. It comes with sugar also. Now, what's the purpose of adding sugar? So the patient doesn't bottom out.
Okay.
The IV insulin is very strong. If you give it IV, the patient's blood sugar can easily drop. To prevent that from happening, they add dextrose so that it won't drop immediately into a hypoglycemic state. Right now, what they will do, as soon as the blood sugar reaches below 200, they will stop the IV insulin and will continue with what? IV fluids and regular subcutaneous insulin. Continue with subcutaneous insulin. Okay, now, here's the thing. They would usually combine NPH plus regular. Right? The combination of the regular and NPH actually allows the insulin to have two effects. One that is immediate and one that can actually last a little bit longer. You have a maintenance dose. You have an immediate kick, right? You want that immediate effect so that we can lower the blood sugar, but at the same time, you want maintenance. So that's why they mix what? NPH and regular. Now the question, hopefully everyone remembers, right? What's the step of mixing insulin?
Clear before cloudy.
Alright, so very important. I want you guys to know this because sometimes it comes out of the exit. NPH is also called
Intermediate.
So don't forget, just in case you don't see NPH, but you see the word intermediate, that's what they're actually telling you. NPH is also called intermediate. And regular is also called what? Short. Very good. Okay. So regular and short, they're the same thing. NPH and intermediate, they're the same thing. Okay, now, when you mix insulin, of course, you're gonna put air first, right? You put air. What's the purpose of putting air? To make it easier for you to draw insulin, right? Okay. So when you put air, the sequence is, if you put air, you go from cloudy to clear. And when you draw insulin, you go from clear to cloudy. I'm gonna write it down. Air, you go from cloudy, which is our cloudy, NPH or intermediate, right? You go from cloudy to clear, and then when you draw, you're gonna get the insulin already. You go from clear to cloudy. Anyone with a question? Can Can you like imagine it, what's going on there when you put air? Right? So, I don't have any two containers here, but later on I'll get one. I'll get a sample and I'll show you how you do it. What you do is you inject air into the NPH, right? And then you inject air into the regular, and then what do? You flip it. You draw the insulin from the regular, right, or short acting, you pull it back, and then you go to the NPH and you what? You flip it again, and you draw from the NPH. Okay? So, air, cloudy to clear, draw, clear to
Cloudy.
Okay. Good? Everyone remembers that? Alright.
Cloudy to clear, then clear to cloudy.
Nurse in a provider's office is collecting data from an older adult client who has type 2 diabetes mellitus. Which of the following finding is the manifestation of hyperglycemia? Hyper.
Poor wounded? Yeah, B. So the answer is letter B.
B. Very good, guys. Letter B. So clammy is hypo. Decreased urine output is, I don't know, that's not even there, right? And then random blood glucose of 110.
That's normal.
Right?
Yeah.
Because our normal is what? 72. And then, so the answer of hyperglycemia is what? Poor wound
Healing.
Poor wound healing. Very good, guys. Alright, next one. A nurse is collecting data from a client who has diabetes and is overweight. The client tells the nurse that she wants to start an exercise program. Which of the following actions should the nurse take first? Now, before we go and answer this, which member of the healthcare team would you ask for collaboration, for a referral?
Dietitian and the
Other than a dietitian, the focus is exercise program.
physical therapist?
It'll be who?
PT?
Physical therapist. Very good. Physical therapist. Okay. All right. Very good. So, which of the following actions should the nurse take first?
Assess. A. Determine.
That's right. Very good. Look at that. Yes. Letter A. Determine the client's usual pattern of activity. Now, of course, we're also going to need dietitian consultation for this one because the patient needs to know that he has 3 sources of nutrition, right? Which is complex carbs, protein, and fat. That's what they should take, right? Complex carbs, protein, and fat. And it's important that before they start the exercise, that they should check their blood sugar before exercising and after. Okay. They need to do that in order to make sure that it's not dangerous for them, whatever is the physical activity that they are doing. So the nurse is reinforcing teaching to the client who has diabetes about which dietary source should provide the greatest percentage of her calories. Which of the following client statement indicates an understanding of the teaching? Letter
B.
Letter B. I
Complex
should
carbs.
eat more calories from complex carbs. So what are examples of complex carbs?
Whole grain.
Vegetables, brown rice,
Yeah.
wheat, barley, rye, right? Things that are what? Harder to digest. Harder to digest. Okay. Quinoa, right? Another one. Pretty good too. Is that clear, class?
Yes.
Alright, very good. Alright, last one. Here we go. Mixing. This is one of those examples of how this might come out. A nurse is preparing to administer 10 units of regular insulin, and 20 units of NPH insulin to a client. What is the sequence of events that the nurse should follow?
C. Inspect first.
So inspect the vials for contaminants, that's number 1.
And then
And
check
then
air.
A, roll the NPH between the
Okay.
palms of the hands, and then
Then D. Inject air first.
alright, let's see. Let's put the numbers in. So 1 is inspect for contaminants, right?
Okay.
The second one is to roll the NPH between the palms of your hand because you want to make sure that they mix well. Can you shake it?
No.
Right.
Roll it.
What's number 3?
D.
Inject air into the
NPH.
D, NPH, and then inject air to the regular, and then
Roll out the.
withdraw from
Short
the
acting.
short, and then
And then yes.
very good.
That's the way.
Okay, very good, guys. That's the sequence. Okay, so don't forget those steps. Alright, good job, guys. Okay, so a few things to. Everyone got this already? Don't worry, I will upload it for you guys. Okay, don't worry if you miss any of the questions. So here are some of the things to remember about diabetes. Right? You have diabetes type 1, you have diabetes type 2. Type 1 is an autoimmune disorder, genetic, right? There's really no way of correcting that
Yep.
because you have a defective gene that causes your pancreas to not produce what? Insulin.
Insulin.
So type 1 diabetic, they will not survive without insulin. They really need insulin. Right? Now type 2 can start off first with oral anti-diabetic, right? And if they're managing their condition right, type 2 can actually be reversed. Type 2 can be reversed as long as you're managing it right. But if you don't, then eventually your type 2 can become a type 1 and you're going to be dependent also on insulin. Now, very important, this will come up also. Which one is the best diagnostic test for diabetes?
H1C. A1C.
HbA1c. Alright, now take note. That has a name. It's called glycosylated hemoglobin. Okay, so don't forget. If you see this name,
Glycosylated hemoglobin. Yes. Yes.
you can go on the bottom. Oh, there you go. There you go.
Yes.
Right here. There you go. Glycosylated hemoglobin. There you go. A1C. Okay? So don't forget, that is the same. HbA1c, glycosylated hemoglobin, they're the same thing. It is done every
3 months.
3 months, right? And API, they're very they only gave you 5.7. So, but the normal range is actually 4 to 6. Okay? So just don't forget, the normal range for HbA1c is 4 to 6%. Now, follow, of course, what is being given to you on the test. If, let's say, they use the 4 to 6, you know that someone who is diabetic would have an HbA1c of less than 4 or greater than 6.
Greater than 6.
6. Good. A diabetic patient, early stages would have greater than 6. Okay? Alright, so is that clear for our interpretation? Alright, so other than that, please do not forget this. This is gonna come out. 45% carb, 15 to 20% protein, and 20 to 35% fat. So as you can see, the best source of their food comes from complex carbs, followed by fat, followed by protein. Don't forget get down. Okay.
45%.
All right. Any questions so far? No. The next one. They're going to ask you this. Another sequencing test on our exit. How to do a random blood glucose check. Okay. How to do a random blood glucose check. So always remember, the best side for doing it are the fingers. You can use the pinky, you can use the thumb, but they are usually the last option. It's the last option. Okay, why? Pinky is too small. You can create a lot of damage here. The thumb has a pulse, so you don't want to hurt that pulse also. Okay, so you would usually pick either the index, the middle, or the ring finger. If the patient's hands are cold, you can either what? Apply a warm compress. And remember, when you say dependent position, that means lower. This is elevate, this is dependent. So if you want more blood to go to the hands, you put it in a what? Dependent position. Okay, again, don't forget that. You want to put more blood into the hands, put it dependent. They don't elevate it. If you elevate it, nothing will go here. That's why if you want to prevent swelling, what do you do to prevent swelling?
Elevate.
But if you want a lot of fluid to go there, what do you do? Dependent. So if someone has a fracture, how do you position the fracture? Dependent or elevate?
Elevate.
Dependent or elevate? Fracture. Dependent or elevate?
Elevate? I'll say elevate. I am like, yeah. I'm second guessing myself. I don't know. It is elevate. I was. Oh, mother.
Fracture is elevate, right? Because what? You don't want the fracture to swell up because if they have a cast
But
and the
hand
arm
dependent.
swells, that's a risk for
Syndrome.
But
But
don't
hand
forget,
dependent.
fracture elevate.
Grease.
You want for blood sugar check, dependent. Okay. Okay. Use the side of the fingers. Alright, not the tip, not the bottom, side of the fingers, right? And you will clean it with an alcohol pad. You allow it to dry for a few seconds, use the lancet. The first blood that comes out, wipe it off. Yeah, wipe it off, right? Don't wipe it in alcohol though, okay? Wipe it off. And then you get the second blood as the specimen, right? And then you ask the client to apply pressure for 2 to 3 minutes, okay? Now the reason behind wiping it off, what's the reason? So we can eliminate more the error of possibly having alcohol in the first blood. So that's why you wipe off the first blood that comes out. Apply pressure, alright, and then you read the result. Now, can we delegate this to the UAP?
Yes.
Yes, we can. Okay? As long as the UAP doesn't do the recheck, and as long as the patient is not acutely ill, okay, we can delegate this to a UAP. A UAP can check blood glucose. Okay? Is that clear, guys?
We can check blood glucose.
Alright, here you go. And here are the manifestations of hyperglycemia. Polyuria, polydipsia, polyphagia, too small, recurrent infection, and then you have your acetone or fruity red. You get that. Alright, and here are the signs and symptoms of your hypoglycemia. So don't worry, don't write it down anymore. It's gonna be, I'll upload this to you guys.
Recurrent infection.
Alright, now, Next one. I want to show you a picture because this is going to be a picture question of how to administer subcutaneous injection. So remember the picture.
Oh God.
Alright. Good, there you go. Okay, so don't forget, when you're doing a subcutaneous injection, primarily insulin, you have to pinch the actual what? Skin. Now, before we go there, what is the best site though for subcutaneous injection?
Abdomen.
The abdomen. The abdomen. Okay, you can either use the right lower quadrant, the right upper quadrant, the left upper quadrant, and the left lower quadrant. You want to do that because you want to rotate sides, right? So you want to use up as much as you can the right lower before you go to the right upper, before you go to the left upper, before you go to the left lower. Now, subcutaneous injection, you need to make sure that you hold the skin first so you can get more adipose tissue. Okay? And when you inject, you can either use a 45 degree or 90 degrees. Okay? So you can use either 45 or 90 degrees. So please make sure, remember how the picture looks like. So again, you can use either 45, you can use 90 degrees, right? And remember though, if you are using the abdomen, you should be at least 2 inches away from the umbilicus and about 1 inch away from any holes or scars. Okay? 2 inches
You're gonna confuse us.
and 1 inch away from holes and scars. Alright? So there you go. Please do not forget, okay? Subcutaneous injection. Okay? Do we need to aspirate this to check if we're in a blood vessel? No. No, we don't. Right? We don't do that anymore. Even IM. We don't. What is the best thing? Alright. So here's the answer. The question was, what is the best? 45 or 90 degrees? It depends on the patient. Why? Patients that are skinny, what
45.
are you gonna use? 45. Those who have more adipose,
90.
90. Look at that. You guys hear that? That's a good technique. That's a good technique. 45 if they weigh less, because 45 is less, right? And 90 if they weigh more, because 90 is more than 45.
Umbilicus.
Alright, any question? No, we're gonna break, okay? So be back by diabetes is on meningitis, increase intracranial pressure, because it can be one of the long-term problems with well, it could be like a complication of meningitis. And then the other one is okay, and the
I want to say C.
the other one is seizure. Okay, so that's what we're going to be focusing on. So here's our example here though. This one though is on the complication of meningitis, which is intracranial pressure. In this situation though, the nurse is assisting with caring for a client who has a concussion
D.
following a motor vehicle crash. The nurse should monitor the client for which of the following manifestations of increased intracranial pressure. And then we'll discuss the focus on this and the X. What do you think is a manifestation of increased intracranial pressure? The answer is
D?
letter
D?
letter D. Letter D. Letter C.
I always believed in you, Evelyn. I said I always believed in you, Evelyn.
Answer is letter D. Okay. Now, don't forget, battle sign is actually not intracranial pressure.
What
This
is
is
that?
basilar trauma, okay, or base trauma, basal skull trauma.
Battle sign.
Polyuria, this is actually diabetes insipidus or diabetes mellitus, right? PI or DM. You can have polyuria on both. And then knuckle rigidity, this is the one that
Meningitis.
is meningitis. Okay, now, very important. Another positioning question. How do you position a patient with head trauma?
Neutral spine.
Head of bed, up or down? Or sideways?
Up.
Up, very good. Okay, so semi-powders to powders. The head of bed has to be up. Why? Because they have a head trauma, so the problem there is swelling, right, of the head. So if you want to reduce the swelling of the head, you want it to drain. So in order for it to drain, you want the head of bed to be up, right? Head of bed up. Head of bed up. Now, the other thing that's also on this one is
Cushing's.
alright, Cushing's triad, right? So
What is that?
Cushing's triad, it's not your Cushing syndrome. Okay, Cushing's is different. Cushing syndrome is a problem with increased cortisol,
Yes.
right? That's when you get that buffalo humps, moon face, right? Striae, ascites, right? This one is different. Cushing's triad is called triad because it is the three manifestations of increased intracranial pressure. Now, there are two triads that might come out of your exit. This one and the other triad is
Can you move that part a little bit to the side?
this one. Yeah.
Thank you.
There you go. Sorry about that. Okay.
You did it.
Day one, you should have asked.
All right.
I didn't know that was an option.
So, there you go. So, there are two triads, okay, that's going to be on our exit. Cushing's triad is one of them, and the other one is thyroid storm. Alright, so we'll talk about thyroid storm, the manifestation, once we go to Graves' disease. But this is one of those triad that might come out. So when you say Cushing's triad, these are the three main manifestations of increased ICP, which is, number one,
Bradypnea.
bradypnea, meaning slow
Respiration.
respiration. Bradycardia, which means
Slow heart rate.
low heart rate. And then the other one is what we call as, what do you call that? Systolic hypertension, or what's the term? Pulse pressure. There you go. Thank you I almost forgot. Wide pulse pressure. Okay. So it's easy to remember bradypnea, bradycardia, right? You just have to remember you have slow respiration, slow heart rate. Now, when you say wide pulse pressure, how do you determine if they have a wide pulse pressure? What you do is, let's say, for example, you get 3 sets of blood pressure. Let's say you get 120/80. After an hour, you get another one. You get 140/70. After an hour, you get another one. You get 140/60.
Okay.
One thing that you would notice on the
Diastolic.
3 blood pressures that you have taken, what do you notice?
Diastolic is going down.
The systolic
Is going up.
either goes up or remains the same, while the diastolic one drops. Very good. So don't forget that. Okay. That's how a wide pulse pressure looks like.
It's the same.
Systolic either goes up or remains the same, while the diastolic one
Goes down.
drops. And then what you do is you get the systolic and you minus the diastolic. Alright? And if the difference is 60 or more, guess what? The patient has increased intracranial pressure. So if you do this, the difference is what? 40. Here, the difference is 70. Right? Yeah, 70, right? So that here alone, you already know the patient has what? Increased intracranial pressure. Because the difference between the systolic and the diastolic is 60 or
Greater.
more. So that's a sign of what? Wide pulse pressure. Okay, now if you see the blood pressure is actually like this, what is this one?
What?
That's not wide pulse pressure, right? That is what? That is hypotensive. That is hemorrhaging. Right? Why? Because if someone is hemorrhaging or having hypotension, both the systolic and the diastolic what?
They're gonna drop.
So take note of that. Do not pick where the systolic and the diastolic both drops. Okay, don't pick that because that's what? That's hypotensive. What you should pick is an answer where the systolic either
the same,
goes up or
or up.
remains the same while the diastolic what?
Goes down.
Drops. Okay, is that clear? When it comes to increased ICP, when it comes to increased ICP, the systolic either goes up or remains the same, and the diastolic what?
Drops.
Drops. That's what we call as wide pulse pressure. And what else comes with it? Bradypnea and
Cardiac.
bradycardia. Very good. Okay, so don't forget the manifestations of Cushing's triad. Okay, very good, guys. Okay, go ahead and write it if you want to write it down. You guys are- Good. Okay, so here we go. Here's our next one. We good? So, a nurse is caring for a client who has seizure disorder and reports experiencing an aura. The nurse should recognize the client is experiencing which of the following conditions.
B.
An aura is a what?
Sensory warning.
It is a warning. Okay, so that's one of the things that a patient with seizure experiences before an actual seizure, which is an aura. It's a warning sign. You know, it's a warning sign because if you know that it is dangerous for the patient to have a seizure, then the aura can give you an early warning and you can give the patient, benzodiazepines. What type of benzodiazepine? You can either give lorazepam or Ativan, or you can give diazepam or Valium. Okay, so don't forget this. Very important to know why I'm mentioning it, because when it comes to our exit, they'll ask you for managing someone who has a seizure, and a lot of times the option doesn't make sense. Like, let me give you an example. Managing a seizure. A, put them in a prone position. Is that right?
No.
No, right? We all know we don't put someone who's having a seizure in a prone position, right? What position do we put them?
Sideline.
Sidelining. Primarily the left side, right? Left sideline position, okay? Now the other one is hold the patient to prevent injury.
No.
B, hold the patient to prevent injury.
Don't
We all
restrain
know
them.
we don't want.
Don't restrain.
Don't hold patients who are having seizures, right? Because what? It can actually cause more
Damage.
injury or damage to the patient, right? Okay. The other one is, let's say, for example, they say put a suction catheter on the patient's valve to prevent aspiration. No, we can do that after what? After they seize, but not when they are seizing. Remember, we don't put anything in the patient's mouth when they're seizing. And then D, right? give diazepam IV. Guess what? The answer is
Diazepam.
okay. Alright, why? Because you can actually give diazepam or lorazepam, right? These are benzos.
Diazepam. We're not in here.
Alright, so there you go, okay? So we can either give lorazepam or diazepam, which is Valium, and the other one is Ativan. Because benzos, in general, they are actually what? CNS depressants. Their effect, their therapeutic effect is what? To stop the seizure. To stop or prevent the seizure. So, you know, if you know the aura and you want to prevent the seizure from happening, give the benzo. Okay, because this is also very effective in preventing status epilepticus. If you guys heard about that condition, status epilepticus, it is a type of seizure that just won't stop. You know, it doesn't react to medication, and people can die of status epilepticus. Okay, so what's the right answer? You can pick the answer that what? Give this medication IV, or you can also give it per rectal.
Really?
Rectal. Suppository. Just be careful when you're searching. After the season.
They have seizures, so forget it.
Okay, so there you go. Alright, so don't forget. Very important, just in case you don't remember it, these are right answers. You can actually do that with somebody who's having seizures. And remember, someone else who's having seizures, you loosen the clothing, right?
Mm-hmm.
You need to make sure we loosen it. We put a pillow on there, and we remove all objects that can possibly what? Harm the
Injure,
patient. So don't forget that when it comes to seizure management. Here's another example. On seizure, the nurse is caring for a child who is experiencing seizure. Which of the following actions should the nurse take?
D. Sideline.
Letter D, correct. Place the child in a sideline position. The next one, that's on our exit also. What equipment should this patient have?
Suction.
Sorry?
Suction.
Alright, very good. Suction machine. The other one is young tower. Have you guys seen a young tower?
Oh, it's that little catheter thing?
Younger.
Younger?
They call it the younger.
Young. I don't know how to spell it.
So that's it right there. So don't forget,
Young
okay,
power.
the young power or younger, a suction machine, oxygen, and then also possibility of a tracheostomy set. Okay. Why a tracheostomy set? That's only in case of emergency that the airway closes up. But if not, it's good enough to have a what? A suction machine, a young power, and oxygen. Yeah, if it's multiple choice, then you can do both. If it's not, then the best answer would be the suction machine, or young power, or the oxygen. Alright, guys? Are we, remember that, okay? Don't forget that in regards to what should be on the patient's bedside. Remember, a seizure precaution patient's bed is what? Padded, right? Low bed, padded side rails, padded floor. Okay? Alright, very good. Next one. A nurse is caring for a child who is having a seizure. Which of the following actions should the nurse take? Select all that apply. So, hey, place a tongue depressed in the child's mouth.
No.
Right?
No.
Clear the area of hard objects.
B. Yes.
Loosen restrictive clothing.
Yes.
Yes. Restrain the child.
No.
No. Place the child in a prone position.
No.
Alright, very good. So answer is B and
C.
Yes. It's got this for sure. So both ICP and seizures can be an actual complication related to meningitis. Okay? Although, of course, some patients with diagnosis of epilepsy, they can have seizures, but meningitis, those who are infected with this can also develop either ICP or seizure. Now, very important, they might ask this, okay, they must come out. If the question comes out on what should be the immediate action of the nurse for a patient suspected of meningitis, the answer is isolate them immediately.
Yeah.
Okay? So, when it comes to contagious diseases, especially COVID, suspicion of COVID, suspicion of TB, suspicion of scabies, C. diff, meningitis, the most important thing for the nurse to do first is what? Isolate.
Yeah.
Isolate, okay? Because why? You're trying to minimize infection. You're promoting infection control. After isolating the patient, then you can do further what?
Evaluation.
Diagnostic
Yeah.
tests. To check. Just imagine
Suspect.
you didn't isolate someone who has TB and you let them roam around while you're assessing them. Guess what? The next day, everyone has
TB.
TB. Everyone will have TB. Okay? So what do? Isolate them
Isolate.
immediately. Now, meningitis, what type of isolation precaution?
Those. Oh no, it's droplet.
Droplets. Very good. Okay. Droplets. Okay. Meningococal meningitis, just like your RSV, is droplet precaution. Okay. Pertussis is also droplet.
Yeah, man.
Okay.
Measles, TB,
So,
tsaka
for
varicella.
someone who has droplet, you want to make sure that they can be in a semi-private room as long as the patient that they're with also has the diagnosis of
Meningitis.
meningitis. Simple diagnosis. They have to be placed away from the windows and away from doors. Alright, next, really quick, for our signs and symptoms, they might ask this, so just don't forget this. Okay, very important. Just don't forget that. It
What?
might come out.
Kudzinski sign? And Kernick?
Just try to remember as much as you can. Yeah, the whole thing.
Oh,
The
no.
whole thing. I know it's hard, guys, but try to remember as much as you can. Okay. Just remember, you see the word Brudzinski, the word Kernig, the word nuchal rigidity or stiffness.
Meningitis.
You know they're talking about
Meningitis.
Meningitis. And remember, meningitis pain, especially the headache, is not mild, it's not moderate, it's what?
Severe.
It's severe.
Severe pain.
Okay. So just try to remember that page as much as you can. And then of course the test for meningitis is
CSF.
spinal tap or cerebrospinal fluid. Another positioning question. It asks you, how do you position a patient for a CSF or spinal tap? Side lying,
Side-lying, knees up.
chest,
Yeah,
right?
near the chest.
Side lying. If the knee chest side lying is not there, please pick orthopney. Okay, so how does an orthopney position looks like? They're like on a chair and they're actually what? Hunched forward to expose the area of the lumbar spine. Okay, so that's orthopney. So the next best answer is this, okay? Just in case the knee chest side lying is not there, the next best answer is
That's sideline.
orthopney
Or,
position. So, sitting down, hunch forward with the arms on the table.
Position.
Okay. All right, very good. Any question? So we went over those medications. So good go. Yeah. Right, and then we did discuss about seizure already, right? Okay. So we did went over that. So don't forget the medication, diazepam and lorazepam.
Where the Yes, the recipe.
Alright, and then those are the things that we talk about in managing patient who's having a
Seizure.
seizure. Alright, very good. Then here are just some of the plan of care after a seizure. Let's see if I forgot some.
That's good.
Very good.
Almost got.
Any questions, man? No? Alright, we'll move on to our next topic, which is ortho musculoskeletal. We have two arthroplasties, although the focus is on hip arthroplasty. Now, before we go to hip arthroplasty, I want to show you this. Don't forget this. It's going to be on our exit. It's called phallic harness.
Oh, tablet?
Alright, so don't forget this one. I'm gonna ask you
Dysplasia
about
para sa mga
phallic harness. There you go.
hip dysplasia.
Okay, phallic harness. It's a form of cast. The only thing is this is actually for infants younger than 6 months. Okay, so if the infant is already older than 6 months, then the next option would be a spica cast. Okay, now if they're younger than 6 months, they use what we call as phallic harness. Don't forget this, okay? This is how it's spelled. Alright, phallic harness, okay, with a K, right there. So phallic harness is for the management or treatment of hip dysplasia. Okay, hip dysplasia. So when you say hip dysplasia, there is a displacement of the newborn's hip. You know when they do a click test? If the mom had a dystocia or difficult delivery, then they usually would do, especially advanced age mom, they would do a click test. They would do an ultrasound and then do the positioning test. And if they find the patient or the newborn positive for hip dysplasia, they'll put the newborn on a phallic harness. So again, it's only good for up to 6 months, no more than that. If they're older than that, they will be switched to what we call as a spica cast. The spica cast, it's crazy the way it looks like. But for younger than 6 months, they'll go to phallic harness. Okay, so a few things to remember. When the patient is on a phallic harness, you cannot make adjustments to the strap. Okay, you can't make adjustments to that. So if you are to remove this because the child actually gets soiled and you need to change the diaper, make sure that you're not adjusting the straps. Only doctors are allowed to adjust the straps. Okay? So you need to make sure that if you remove it, just remove the center, the central velcros. Do not move the side straps. Okay? The next one, the diaper should be inside, not outside. Okay, so it's not the phallic harness inside and then you put the diaper on top. No, it's the diaper first. The diaper will be on the bottom or the inside, and the phallic harness will be outside. Okay, why? We don't want that to get dirty. Okay, yes.
Do you take it off to bathe them?
I'm sorry. Yes, you can actually take it off to bathe them, but here's the deal. If you're gonna do that, you have to keep the legs what?
Flex.
Abducted.
Oh,
Okay,
okay.
so that's the term.
Have the corner.
Right, so not adduct, alright? Because the word adduct means to put together, right? Add. This one is abduct. So meaning that if you're gonna do that, because we
Yeah,
don't
put it
want this to
close.
get wet, you're gonna make sure that you keep the legs what? Abducted, separate
Yeah.
from each other. Okay? Because if it ever comes together, what's gonna happen? It's gonna displace the hips again. Right? Now, very important. If you are bathing newborns, especially with phallic harness, always remember that you actually have to wet the head first before the body. Okay, so head first before the body. Okay, why? Because we don't want the baby to get cold. We can easily lose body. So what do you want first?
Head.
First, body last, so that you can immediately already what? Dry. Okay. Don't put the phallic harness back wet. Make sure that the baby is dry, and always remember to keep the legs
Abducted.
abducted. Okay, that's the same concept that you have to remember for plan of care for hip arthroplasty. Anyone who had a hip surgery, remember they're not allowed to what? Cross their
Abduct,
legs,
yeah.
right? It's important that they keep their leg separate from each other, right? That's why in the early stages of healing, they're using a leg abductor pillow, right? To keep the legs abducted. And now for babies younger than 6 months, the way they keep the leg abducted is through a phallic harness.
Harness.
Okay, so don't forget the phallic harness. Okay, guys? Alright, very good. Any question on the phallic harness? Now, usually the length of treatment will be anywhere from 6 to 12 weeks on the phallic harness. 6 to 12 weeks on the phallic harness. You're not gonna forget, right, how the phallic harness looks like.
Mhm.
Alright, so here is our hip arthroplasty question. A nurse is contributing to the plan of care for an older adult client who is post-operative following a right hip arthroplasty. Which of the following interventions should the nurse include in the plan? So this patient has a hip surgery. They did a hip replacement on the right hip.
Yeah, maintain abduction. D.
The answer is
D.
letter D. Very good. Maintain abduction of the right hip. So that means keep the legs apart. Right? Keep the legs apart. Okay. Good? We good? Alright. Next one. A nurse is contributing to the plan of care for a client who is post-operative following a total hip arthroplasty. Which of the following information should the nurse include?
Wait. Maybe A? I don't know.
What's the answer? Letter B. Letter B. Right. Prevent hip flexion. So, a few things to remember. Hip arthroplasty patient should be sitting on a high chair.
Mm-hmm.
Right? Why? Because you want to keep the thigh
Oh, 90.
extended, not flexed. So, if you lower this, right? Yeah, this is what happens when you're 95 pounds. But here's the thing. Here's the thing. Hip flexion means that when your thigh goes like this. Right? So if you're sitting down on a low chair, your thigh tends to go up like that. That's flexion. This is a problem. Why? This will pop out the hips.
Oh.
Okay? So keep the thigh extended, not
Okay,
flexed.
flex.
Okay?
Okay.
The other thing to remember, other than a high chair, high commode, you're not supposed to use a regular toilet seat because that could be too low. So you want a high commode. You want the cushion to be firm, not soft. Why? If it's soft, they're gonna sink. You're gonna do hip flexion again. You don't want that. So that's another thing that's important for hip arthroplasty. Okay, so again, high chair, high commode, no regular toilet seat. The cushion should be firm. Keep the legs abducted or separate, right? And if they are to be repositioned, and they're going to be repositioned with the leg abductor, you need to perform lug roll. Okay, so don't forget about lug rolling. Lug rolling is when you move the patient's body when all at the same time, right? When you lug roll. The leg, the body, the head area, they all turn at the
Same time.
Okay, so don't forget that for hip arthroplasty. Okay, that's very important, guys. They're gonna ask you about plan of care. Okay. It's also important that if they are to be discharged home without the leg abductor, that we remind them to put a pillow in between their legs when they sleep.
Yeah, abductor pillow.
Put a pillow between their legs when they sleep. Alright, very good. Any question on this one? Next one. The nurse is reviewing the diagnostic test result of a female client who is about to undergo knee arthroplasty. This one is knee. Which of the following data collection findings should the nurse identify as a priority?
A.
That's right. Infection, right? Letter A, the WBC is high, so that means the patient probably has an ongoing
Infection.
infection. We're in, you need to report that. Next one, the nurse is caring for a client who is to undergo total knee arthroplasty. Which of the following actions should the nurse take when participating in the informed consent process? This is just a question.
A.
Just to see if you guys remember it.
A.
Letter.
A.
Find the names. What else? Okay, so the best answer is letter A. Verify the client is giving the consent voluntarily. Yeah, and then the doctor is pretty much more of the one that really tells all of the members of the staff here. Alright, so here's the next one. This is the actual question that's also on our knee arthroplasty. This is what we call as a CPN.
Okay.
What does CPN stand for?
Continuous passive motion.
Passive
Motion.
motion machine, right? Continuous passive motion machine. The machine works by, extending and flexing the knee. Extending and flexing the knee to actually prevent knee contractures. Okay, so this is for the prevention of knee contractures for a knee arthroplasty or knee surgery. So, very quick, just one thing that I just want you guys to remember. If this is to be performed, you have to pre-medicate the patients. Okay, because the question is, how would you help the client to be successful with the use of the CPN? What would you do?
Pre-medicate.
Pre-medicate the client. Why? This hurts. This hurts a lot. And if your patient is not medicated before they do this, guess what? Do you think they're gonna do it?
No.
They're not. So what do? Pre-medicate them first, at least 30 minutes to an hour before you start the CPN. Is that clear, guys?
Yes.
Alright, great. Alright, a few things to remember about knee arthroplasty. You don't have to read all of it, just focus on the CPA.
Okay.
So here are some of the possible treatment, which includes, of course, pain medication before the patient goes into a CPM exercise. Not really important. Alright, the next thing that we are going to discuss really quick. I'm not sure why it's not here. Is it here or is this at the end? Yes, it's right here. How come this is separate? That is so messed up, okay?
What the hell is that?
So tractions, okay? So tractions are primarily not really for knee surgery, right? Or knee fracture. It's more for what? Hip.
Yep. Okay.
Hip fracture. So this is an example of a box traction. Okay, now I want to show you another traction, which is this one right here. Do you guys see this one? This one is small, but do you guys see it? Let me make it bigger.
That's skeleton.
Now, the one I showed you was the box. This one that I'm showing you right now is different from a box because the box is a skin traction, while this one is a skeletal traction. Okay, so it's called a skeletal traction, or the name is 90-90. Okay, 90-90 traction. It's called 90. Okay, so it's a skeletal traction because it actually comes with a pin right there, right? That actually goes through your bone or through the patient's bone.
Oh.
Okay? So for a more severe form of injury or fracture, that's when they use a 90-90 traction. If the patient's injury is moderate, but it does require them to be on a traction before surgery, then they will use the other one, which is called the box, right? The box. This one right here, the box. The box is a form of skin traction. Okay, skin. Right? Now, when it comes to traction, one of the important things you have to remember here, that if you have a patient on a traction, you have to make sure the integrity of the weight. You see that weight right here? That weight has to be hanging at all times. It has to be hanging at all times. Alright, so let's say for example, this question on the exit comes up. It's asking you, you're doing your rounds, you came into the patient's room and you saw that the weight is on the floor. And then the question is, what should be the immediate action of the nurse? So it's asking for immediate action. A, assess the patient. B, report to the physician immediately. C, hang the weights. And then D, call the charge nurse.
Hang the weights.
Charge nurse, call the physician,
Really?
assess, or hang the weight.
Hang the weight.
Right, so here's the answer. Here's the answer, okay? The answer is immediately hang the weight.
Okay.
Yes, I'll explain to you guys, okay? So in reality, when the weight is hanging, can you remove it?
No.
Can you change the weight?
No.
No, unless there's a what?
Order.
An order, right? But guess what? If the weight is not hanging, is it working?
No.
So what is your responsibility as a nurse?
Yeah,
Make sure
it
that
works.
it is what?
Okay.
It hangs. Because the more the time that it's not hanging, what's happening to the patient's fracture? it's getting what? Worse. They're gonna form more fracture, they're gonna form deformities, and at the same time, a lot of things.
Okay.
So, if it's not hanging, what do you do?
Hanging.
That is the time that you can touch it and move it. Because if it's not hanging, it's not working. After it hangs, what do you do?
Leave it alone.
Assess the patient,
Oh, yeah.
and then report it to the charge nurse, and then the physician. Okay? But it's important that you actually what? Hang. Don't forget that. Okay? Now, the other thing, because we want to keep this hanging at all times, if the patient is to be moved, you have to move the entire bed with the patient. Okay? To make sure that the weight is hanging at all times. Okay? Now, assessment. The focus of assessment for any fraction is again neurovascular check. A neurovascular check. What is that? Circulation.
Yeah.
Right? Now, if you're to be asked which part of the body will you check for neurovascular check?
The foot, like
Which toe?
the distal.
The right toe or the left toe?
Right toe.
The left foot, right? That's what we're gonna check. The left foot. The left foot.
Okay.
Okay, now, if we are to assess the left foot, because they ask you this as part of your assessment, what are the pulses that you're gonna check?
Pedal.
So you have the dorsalis, pedis, and then the one on the inner side, right? Of this one right here,
Yeah,
right?
whatever that's called.
Which is the posterior
Tibialis. Dorsalis pedis.
tibialis, right? Or medial tibial pulse. So don't forget, there are two pulses, dorsalis pedis and
Posterior tibialis.
posterior tibial pulse or medial pulse. Okay? Right, that's what we check. We check for what? The pulse, capillary refill, temperature, color. Okay, so don't forget that. You have to do the assessment here because this is the one that is at risk for compartment
Syndrome.
right? Check for skin integrity. Now, going back to the other traction, which is the 90-90 traction, there is one additional assessment that you need to do for this one.
Depends. Pin
What is
sites.
the additional assessment? Other than neurovascular check
Insight.
for infection. Very good. Where do you check for infection? On the location of the
Insights.
pins. Okay, on the location of the pins.
Fiction.
Okay, we need to check the location of the pins. Okay, now, the pins, very important to know. If they describe this on our exit,
Set us like this. Clear.
serosanguinous and serous, do we need to report that immediately or not?
No.
No, that's what? That's acceptable.
Yeah.
Okay, so don't forget that. Okay? Acceptable. What do we report?
Sanguinous.
Check that. Correct. Very good. We report
Purulent drainage.
number 1,
Sanguinous.
sanguinous, and the other one is
Purulent drainage.
purulent, right? Sanguinous means we have blood, so we have bleeding in that area. We have to report that. Sanguinous means blood. Purulent means pus, so we have a sign of infection. So we have to report that also. Okay, so sanguinous and purulent report. Serosanguinous and serous acceptable. Just what? Continue to monitor and
Document.
document. Is that clear?
Yes.
Right? So if the description is serosanguinous and serous, the drainage, continue to monitor doctor. If the description is sanguinous or purulent, report immediately. Okay, why? Sanguinous means bleeding, purulent means fresh. Okay, or pus. Is that clear, guys? Yeah. Very good. The next thing, very important, for both bugs and 90-90 traction, you cannot turn the patient side to side. So if you want to clean them, you will probably notice on one of the picture, they actually have a trapeze bar, which means the patient uses that to lift themselves so you can actually clean them from head to foot. You can turn them. So on our exit, if they ask that while doing your rounds, you see that the family members are helping out with the patient to turn the patient to their side, what would you do? Immediately what?
Yeah.
Stop
Come
the
on.
family.
Yep. Yeah, come on.
They tell the family, no, stop, don't do that. The patient cannot
Turn
be
patient.
turned side to side.
Use
Back here,
trapeze
guys.
bar.
Okay, very good. So don't forget that they should not be turned side to side. If you're gonna clean them, lift themselves up, you have to be clean from head to toe. Okay? Alright. The next one more. Remember, that's gonna be there. The opposite leg. The opposite leg is actually a risk for DVT. Very good. DVT. Okay, so it's a risk for DVT. Assess that leg for signs of DVT, like what? Swelling, calf pain, or Hamann sign, right? That's what Hamann sign is, all right? But you don't want to perform the maneuver. But you check for pain, you check for swelling, redness, and heat, right? That's all the sign right there of DVT. Have pain, swelling, redness, and you have heat. Right now, what is the best way to prevent this from happening? Range of motion. You do range of motion not on the affected leg, but where? On the opposite leg, right? The one that is prone to DVT. The other one is through the use of TEDs. We're going to ask you on TEDs, okay? TEDs, it's a long name. Thromboembolic deterrent
Stockings.
Right? That's what it is. Thromboembolic deterrent stockings. What does that mean? It is a stocking that prevents the formation of blood clots or thrombus. So very important. Okay, they're gonna ask you this. When you put the TEDS hose, you want to make sure that the patient's leg is elevated and the foot should be pointing forward. Okay, so don't forget, forward pointing. Okay, now what's the reason why the foot should be forward pointing? So that when they move it, there's a what? There's a slack. And it won't be too tight. Okay, is that clear, guys? Now also, the edge can be folded. No, right? It has to go all the way. So that's why you have to measure from where? From the ankle all the way to the calf area right here. Because why? You don't want it to be too long because you cannot what? Fold it. And when you put it on the patient's toes should be out. Right? This is how it looks like. Why should the patient's toes be out?
Circulation, I guess?
So that we can check it for circulation. Very good. So that's why, a lot of TEDS hose, if you look at it, it actually has holes. The one that doesn't have holes, not good.
Circulation.
Let me show you a good example. Well, this one has a hole, but you can barely see it. Okay. This and this is above the knee. There you go. That's a really good one. This one. There you go. Right.
Along the suck.
Hey, what can I say? That's the picture right there. So, alright, so that's it.
Tire the
I
suck.
want to make sure that's not folded, right? Make sure the toes are out. And remember, when they are putting the dead toes on the patient's foot should be pointed outwards. Can you delegate this to a UAP?
Yes. Yeah, tell them to
The
hire the
only
suck.
thing that the UAP can do is what?
None of the food.
Put it on. Put it on and take it off. That's it. Put it on and take it off. So if you want
Yeah, I did
to
that plenty.
check if it's correct, who does the assessment? The license.
Yes.
Okay. Are we clear on this, guys? Dead toes?
Yep.
Yes. Okay, no folding. You have to measure from the ankle all the way to the knee right there. And you want to make sure that the toes are out. Okay, when you're using a dead toes. Very good, guys. Okay. Any question?
Hire the suck.
No question? Alright.
550.
Alright, we're gonna go to our last two topics and then we'll stop there, which is fluid overload and fluid deficit. Okay. Yeah, we will continue with this Saturday before we do our baby exercise. We need to discuss chest tubes. That's I think one of the hard ones. Alright, so let's take a look. A nurse is collecting data from an older adult who is post-operative and is receiving IV therapy at 125 ml per hour. The nurse should identify that which of the following indicates the client is experiencing fluid overload. Right, so overload, alright? So meaning there's too much water or fluid in their body. Let's take a look. A, is this fluid overload? No. What is the description for A? This is
Infiltration.
Alright, very good. That's infiltration. So no. Flat neck veins.
No.
No. Flat means
Yeah.
deficit or dehydration. Very good. Bounding radial pulse.
Yes.
Yes. What is for dehydration? What would be the pulse? Rapid, weak, and ready. Very good. Periorbital edema. Yes, periorbital edema. That's also fluid overload. And then freckles in the lungs. Yes, that's also fluid overload. Okay. Also fluid overload.
Flat neck vein.
Okay, now the other thing that I would like to add, fluid overload. Fluid overload, when it comes to VUN, this would be a VUN of less than 10. Okay, remember, why? Because the normal VUN is what? 10 to 20. If the VUN is greater than 20, that is a sign of what? Dehydration. So a VUN of less than 10 is a sign of fluid overload. Very good. Okay. The other one is a hematocrit of less than 37%. So meaning the blood is very diluted. Right? So that means the blood is diluted. Thick means when you have a higher percentage, right? Yeah. Overload, right? So this is overload. Yes. So hematocrit of less than 37 would be a diluted blood. So then we have fluid overload.
Yep.
Okay. All right. What are other signs of fluid overload that might be included? Don't forget. Sightings, right? Correct. Weight gain. Shortness of breath or freckles in the lungs, right? Pink frothy sputum. Pink frothy sputum. Okay, and then of course,
Distend the jugular veins? Yeah, jugular vein distension.
Jugular vein distension of the neck. And then of course, pitting
Edema.
edema.
I guess we're not going to matter.
Alright, good. Go ahead and write it down. Alright, the next one. The nurse is collecting data from a client who has dehydration. Which of the following findings should the nurse expect?
C. Urine output.
Letter
C.
Yes, very good. Alright, so.
Less than 30. Means bad
So the
kidney.
usual manifestation of dehydration is your oliguria, and then if it gets worse, it becomes
Anorrhea.
anuria. Alright, so the term oliguria means that their urine output is only between 100 to 400 ml per day. So you already know they're dehydrated at that point. If the dehydration becomes worse, they're gonna become anuric. When you say anuric, they do what? They don't urinate at all, right? Or their urine output is less than 100 per day. Okay. Now, other than that, of course, their BUN is gonna be greater than 20, and they will have a hematocrit of greater than 52%. Right? So that means that the blood is really very
Viscous.
concentrated.
Yeah.
Okay. Alright, of course, for young individuals and children, they can have tenting, and then also weight gain, weight loss.
Weight loss.
Weight loss. That's right. Weight
Tenting
loss.
scan.
Dehydration. Weight loss.
Weight loss.
The pause is rapid, weak, and ready. Capillary refill greater than 3 seconds.
Capri.
Vocabulary refill, it will be, what do you call that? Greater than 3 seconds. That would be wrong though, because if they have fluid volume deficit, I'll ask about that. If they have fluid volume deficit, that means their circulation is not good. So how can you have fast capillary? I doubt that. That one, I'm gonna ask that one. That one looks like they made an error there, right? Because
Which one is that
if
one?
you think about it, a fast capillary refill means you have good circulation.
Circulation, yeah.
Circulation is good, but how can you have a fast circulation or good circulation and dehydration? Right? I'll ask that. Thank you for mentioning that. But I'll
Good job,
ask
Miguel.
that for sure. I will ask that for sure. Yeah, perfect. There you go. Alright, but there you go, guys. Okay, don't forget that one. I will ask about that capillary refill. Alright, any other question?
License.
Very important, just in case they ask on electrolytes, don't forget, for someone who has fluid volume overload, the electrolyte becomes less. Okay, why? Because the blood becomes very diluted. For someone who has dehydration, you see this? Sodium 142. This would be wrong because this is a normal sodium. For someone who's dehydrated, their sodium would be greater than 140. Why? Because the blood is very
Concentrated.
concentrated. So yeah, but I'll ask about that capillary because it's I highly doubt it. Alright, any other question, guys? Alright, so we're gonna take a break. 15 minutes. We need to go restroom, get some drink.